you cool cats and kittens. So for our project, we did the colorectal cancer and the targeted therapy of doublet target therapies. Our group had Whitney Burgess, Ariel Hall, Courtney Bruno, and Zach Roy. I'm Zach, and for the first part, I did the basic research part of it. And for the origin of the colorectal cancer, it comes from the transformation of epithelial cells in the luminal surface of the intestinal tract to cancerous cells. The process is by transforming normal epithelium of the colon to an adenoma, which will eventually become an adenocarcinoma. The adenoma start as polyps, but as we all know, not all polyps are cancerous. The main types of polyps are, first, the adenomatous polyps, which are adenomas. These polyps sometimes change into cancer. Because of this, adenomas are called a precancerous condition. They make up about 96% of colorectal cancers. These cancers start in cells that make mucus to lubricate the inside of the colon and rectum. When doctors talk about colorectal cancer, they're almost always talking about this type. Some subtypes of adenoma carcinoma, such as Synget and ring muscinus, may have a worse prognosis outlook. Hyperplastic polyps and inflammatory polyps are the second type, and these polyps are much more common and they are generally not precancerous, so they're not less known. A brief overview of the intestinal epithelium entails on how it was a remarkable capacity for self-renewal. With a regeneration rate of 4 to 5 days, the majority of epithelial within the gut are replaced each time, making the cells much more generate to divide and proliferate, especially in the inner epithelial walls. Subtypes are classified as CMS1, CMS2, CMS3, and CMS4, and lastly, unknown. Under each subtypes and most common areas of findings are listed along their pathways. Okay, I'm done.
Okay, so I'm Courtney, and I'm going to be talking about molecular consequences of a frequently mutated tumor suppressor genes in colorectal cancer. So, adenomatous polyposis coli, APC, is a tumor suppressor gene, and the loss of APC is among the earliest events related to the chromosome instability colorectal tumor pathway. Gardner syndrome and familial adenomatous polyposis, FAP, are caused by pathogenic variants in the APC gene. Attenuated FAP, AFAP, is a syndrome with less adenomas and extraintestinal manifestations due to an APC pathogenic variant at the 3' or 5' end. There are over 300 different disease-associated pathogenic variants of the APC gene. Among the disease-associated pathogenic variants of the APC gene are insertions, deletions, and nonsense variants that lead to frame shifts and/or premature stop codons in the resulting transcript of the gene. The most common APC pathogenic variant is a deletion of AAAG in stop codon 1309. Variants that reduce rather than eliminate production of the APC protein may lead to FAP. Microsatellites, MSI, are short repetitive sequences of DNA and is used when colorectal, endometrial, or metastatic tumor DNA show insertions or deletions when compared to normal regions of tissue. When the deletion involves a termination signal of EpCAM but does not include all of the MSH2 gene and promoter, the phenotype is colorectal cancer. The most common abnormal immunohistochemistry pattern for DNA mismatch repair proteins in colorectal adenocarcinomas is the loss of expression of MLH1 and PMS2. PMS2 and MLH1 function as heterodimers known as mutation L-alpha, which bind to mutation S-beta, and guide excision repair of newly synthesized DNA. The loss of MLH1 and PMS2 indicate an alteration in MLH1, which can be either from promoter hypermethylation or germline variant, while the loss of PMS2 expression indicates a germline PMS2 variant. The MSI seen in sporadic colorectal cancers is due to hypermethylation of the promoter of MLH1, which abrogates protein expression. Peutz-Jeghers syndrome is an early onset autosomal dominant disorder characterized by melanocytic macules on the lips and buccal region. Peutz-Jeghers syndrome is caused by pathogenic variants in the STK11 TSG located on chromosome 19p13. The polyps in PJS are hematomas. So next I'm going to talk about the process or hallmark oncogene that is targeted by our chosen intervention, which is double targeted therapy. So the BRAF protein is sort of a is part of the signaling pathway in cells that is necessary for their growth and survival. This is going to be a BRAF protein right here. In many cancer types, the V600E mutation in the BRAF gene causes the protein to be overly active, leading to uncontrolled cell growth and the driving development of cancer. When BRAF activity is inhibited, other parts of the pathway can compensate by increasing their activity and overcoming the inhibition. In adults with metastatic colorectal cancer whose tumors have a specific mutation in the BRAF gene called V600E and who have already undergone at least one prior treatment are eligible for double targeted therapy with cetuximab and encorafenib. Both drugs are targeted therapies. Cetuximab, which targets a protein known as EGFR, has already been approved to treat some patients with colorectal cancer. Until this approval came about, encorafenib, which targets the BRAF protein, was only approved to treat patients with melanoma whose tumors had BRAF mutations. The V600E mutation in the BRAF gene is found in about 10% of metastatic colorectal cancers and is associated with especially poor outcomes. Combining target therapies to simultaneously block multiple components of the BRAF signaling pathway could improve outcomes in patients with metastatic BRAF mutant colorectal cancer. Cetuximab is a partially humanized monoclonal antibody against the EGFR. Because cetuximab affects tyrosine kinase signaling at the surface of the cell membrane, tumors with mutations causing activation of the pathway of downstream of the EGFR, such as KRAS mutations, are not sensitive to its effects. The addition of cetuximab to multi-agent chemotherapy improves survival in patients with colon cancer that lack a KRAS mutation. Using two therapies that target different parts of the cell signaling pathway that is altered in melanoma by the BRAF V600E mutation slowed down the development of resistance and disease progression to a greater extent than using just one therapy.
Hello, I am Whitney Burgess, and I'll be talking about public health incidence and mortality of colorectal cancer and the epidemiology of risk factors of the cancer. According to the American Cancer Society, the lifetime risk of developing colorectal cancer is about 1 in 23, 4.4% for men, and 1 in 25, or 4.1% in women. There's an increased risk of cancer after 50. It kind of, as you can see on this graph, it spikes quite significantly from 45, 49 range to the 50 range. But it is possible to get this cancer at a young age, and over the past 10 years or so, there's been a 2% increase yearly in those younger than 55. As of 2020, colorectal cancer is the third leading cause of cancer-related deaths in both men and women, and it has an expected mortality rate of 53,200 in America by the end of the year. We're seeing this more prevalent in developed countries. They seem to be at higher risk for colorectal cancer. Regions like Eastern Europe, Australia, New Zealand, and East Asia seem to have a much higher risk. And North America, it also features some of the highest incidence rates for this cancer. The country with the highest incidence rate per 100,000 population is Hungary, 70.6 among males and 29.3 among females, and that would be Norway. So for males it's Hungary and females it's Norway. So there's quite a few risk factors for this cancer. Just like most cancers, they have some kind of common denominators, that being severely overweight, not eating correctly, copious amount of smoking or drinking. The age you are obviously has a higher increased risk of the cancer, and a history of inflammatory bowel disease. History spelled wrong, sorry about that. So, according to a study done by A.H. Wu et al., called Alcohol, Physical Activity, and Other Risks Factors for Colorectal Cancer Prospective Study, done by the Department of Preventive Medicine, University of Southern California School of Medicine in Los Angeles, California. This is an older article, but it still reigns true on the study that was done for the increased risk factors for colorectal cancer. The study had almost 12,000 residents ages 64 to 85 from a local retirement community in California, and was done over a 4.5-year period with 58 males and 68 females that were found with colorectal cancer. And the alcohol drinkers were found to have 2 times more risk, a p-value of 0.002. They have a 2-fold risk increase of colorectal cancer than those that did not drink alcohol. And they were inversely associated with physical activity with a statistical significance p-value of 0.008, meaning physical activity, on the contrary, really severely decreased their risk for cancer, people that were active constantly, as well as those that took vitamin C. So out of those tested, 58%, males 71%, females 48% of that 58%. They developed colorectal cancer. They did drink some type of alcohol daily, compared to the 45% of the remainder of the cohort. So this just showed, amongst other things, because this study did show quite a few different risk factors, but one of those that was very prevalent was that alcohol is indeed a very high risk for someone to gain, not to gain, but to get this cancer. So in order to have a much lower risk of developing colorectal cancer, it is a very good idea not to drink, because the relative risk was 1.5 times higher for those who drank than those who did not. So that is one study that talks about the relative risks and just risk factors of this cancer, but there are several others as well.
So it's Zach again, and I want to talk about the efficiency and side effect profile of the chosen intervention. Efficiency of Erbitux with a type of chemotherapy called FOLFIRI was studied in a clinical trial of 1,217 people with EGFR expressing colorectal cancer that had spread and metastasized to other parts of the body. People who received Erbitux with FOLFIRI who had KRAS wild type EGFR expressing tumors were shown to live 4 months longer compared to people treated with FOLFIRI alone, with these numbers being 23.5 months compared to the 19.5 months respectively. Erbitux can cause lung cancer. Lung disease occurred in less than 0.5% of 1,570 patients receiving Erbitux in clinical trials for colorectal cancer. Adding Erbitux resulted in an increase in occurrence to severe or life-threatening redness or sores of the lining of the mouth, lips or throat, and other digestive organs. Skin reactions caused by certain cancer drugs given after radiation, with an acne-like rash, heart problems, and blood electrolyte disturbances compared to radiation and cyclotin alone. Of the study, 57% seen tumor shrinkage, compared to 39% of that with FOLFIRI alone. Multiple studies have shown that Erbitux was somewhat more expensive than original ideas of combinations, but the rate of incidence showed a positive outlook. Erbitux with Braftovi, with the side effect still remaining of dry skin and mouth sores, increases, and the potential of increasing chemotherapy side effects like hair loss. Although some studies show a higher survival rate and a shrinkage rate almost half of the FOLFIRI alone, it was generally well tolerated with no unexpected side effects. The 2 drug combinations significantly improved survival, and compared to the FOLFIRI and Campostar and Cetuximab, survival was markedly better with the 3 drugs compared to the 2, but slightly more side effects. Average overall survival was 15.3 months with a median follow-up duration of 18.2 months. The range was 16.6 to 19.8 months, and the overall year survival rate was 62%.
Clinical subtypes and patient experience on intervention. Clinical subtypes for this colorectal cancer is CMS1 being an MSI immune 14% disease, hypermutated due to the BRAF mutation. The prognosis is that to two therapies, a doublet had significantly improved overall survival and tumor response rates relative to those who received the standard treatment. The drug combo being encorafenib, being Braftovi, and cetuximab, being Erbitux. Propensity for spread is a reduction in tumor size with a median of 18.4 months among patients in the doublet therapy, meaning that there was a reduction in tumor size, reducing the amount of spread and metastasis, and increasing patient survival to 8.4 months with the treatment. Treatment protocol involved 665 patients with BRAF 4600E mutated metastatic colorectal cancer whose disease had progressed after at least one previous line of treatment. The participants were randomly assigned to one of the three treatment regimes: triplet therapy with encorafenib, cetuximab, and binimetinib, a doublet therapy with encorafenib and cetuximab, or a control treatment consisting of cetuximab and a physician's choice of one or two standard chemotherapy treatments, irinotecan, or the chemotherapy cocktail called FOLFIRI. Patient experience had severe side effects. 50% had severe side effects of those assigned to the doublet therapy, and 61% of those assigned to the control group. Less than 10% of the patients in the doublet therapy stopped all treatment due to side effects, the researchers reported, and allowed the drugs to be administered for longer periods of time than the control, 21 and 19 weeks versus the 7 weeks. And we also found side effects being diarrhea, nausea, vomiting, and constipation. Photosensitivity may also occur due to the growth factor receptor inhibitor of cetuximab, and pyrexia may occur due to the hypersensitivity of allergic reactions to cetuximab. Photosensitivity and pyrexia are known as off-target effects, and they occur due to the cetuximab. The V600E mutation in the BRAF gene causes the protein to be overly active, leading to uncontrolled cell growth and driving the development of cancer. The challenge in targeting this pathway in colorectal cancer is explained by feedback activation. That is, when BRAF activity is inhibited, other parts of the pathway can compensate by increasing their activity, but this was overcome by targeting multiple nodes in the pathway, which is why we use multiple drugs. This works by combining the cetuximab, which inhibits the EGFR protein, being the epidermal growth factor, and braftovi, which inhibits the MEK protein, a recombatant chimeric monoclonal antibody directed against the epidermal growth factor, using antineoplastic activity. EGFR is overexpressed on the cell surfaces of various solid tumors. Cetuximab binds the extracellular domain of the EGFR, thereby preventing the activation and subsequent dimerization of the receptor. The decrease in the receptor activation and dimerization may result in an inhibition in signal transduction and anti-proliferative effects. This agent may inhibit EGFR-dependent primary growth and metastasis. The therapeutic toxicity rate was at 300 milligrams for the drugs.